The concept of organ transplant is we are transferring somebody's cells, tissues, or solid organ into another person. Now, each one of us have a unique cellular signature
1597.
wherein no two persons' cells are alike, just like DNA. So on the surface of our cells, we have what's called HLA, human leukocyte antigen. This helps our immune system identify native cells versus foreign cells, meaning as our cells bump into each other, specifically the immune system cells, as they encounter cells, as they circulate in the bloodstream, they bump into each other. They can recognize it based on the HLA, meaning it matches. When you bump into one cell, bumps into another, it's a perfect fit. Okay, so it's recognized automatically. Oh, self, 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 self. And then whenever they encounter a foreign body, such as a virus, a bacterium, a fungus, for instance, foreign to the body, then it's automatically identified. Oh, non-self. All right. So because of this fact, now we have to find a close enough matching donor because unless you have an identical twin, then you will never get a perfect match. Now, how many of you here have identical twins? Okay, very rare, yeah? So therefore, when you need an organ someday because your own organ failed, then you'll have to settle with a close enough match. Okay. Now for this chapter, we'll use this as an example this is chapter 48 under kidney transplantation. We'll use this as an example in identifying and managing organ transplant rejection. Okay, this one is specifically for kidney, obviously. Now, this will also apply management-wise and also pathophysiology-wise. This will apply to any other solid organ being transplanted. They're not talked about in one particular chapter because obviously, so if we're talking about a heart transplant, which chapter will you find it? In the heart cardiac chapter. And what about a liver transplant? In the liver chapter. Okay, so we'll just use this because I found the most specific explanation in this chapter. Kidney transplant are the most commonly performed transplants among all other solid organs. So let's begin. There are 3 types of rejection. We will answer 3 questions for each type. They are: what happened? When does it happen? And what can be done about it? Now, the signs and symptoms is specific to the organ, meaning every organ transplant, of course, will vary. Depends on what did you transplant, okay? So when the concept of transplant rejection is, that means that the host immune system attacked and destroyed the transplanted organ. We'll call the transplant recipients as the host, for discussion purposes, and we'll call the solid organ being transplanted as the graft. Okay, any questions so far? Okay. So again, we'll answer 3 questions because the signs and symptoms will basically be failure of that organ. So for instance, if a kidney transplant is being rejected, what manifestations will you see? Kidney failure. Okay. What about if it's the heart that was transplanted and was being destroyed? Heart failure, liver failure, and so on. Okay, it's pretty simple. All right, so there are again 3 types of organ rejection. They vary as to what happened, when did it happen, and what can be done about it. I repeat again, there are 3 questions basically for each type of rejection. What happened? When did it happen? And what can we do about it? First is hyperacute. This type of rejection occurs within 24 hours. It can also extend up to 3 days, up to 72 hours. It's still called hyperacute rejection. It's the rarest among the 3. The most common type of rejection is the second one, which is acute, followed by chronic rejection. Okay, so let's start with hyperacute. So this type of rejection is very rare, extremely rare, because we've done our homework. We don't just do transplant overnight. Okay, so there's long planning being done here. Even if, let's say, you're on the transplant list, right? And you are waiting for an accident, for instance, to happen, wherein we have a matching donor, then in that case, it can be done overnight, but still doesn't mean we did not prepare long ahead, meaning we already have your testing done, okay, just in case something pops up, okay, we have a matching donor, suddenly, like in a few hours, somebody gets into a fatal accident and that happens to be a perfect match, for instance. So meaning we've done due diligence in preparing for the transplant, but yet it happened. So what happened exactly in a hyperacute rejection? This one, the reason why we cannot stop it, which answers the question, what can be done about it? Nothing. In a hyperacute rejection, because what happens here is it's just a fluke wherein the graft, which is the organ you transplanted, triggered something in the host, wherein it triggered the clotting cascade. As a result, long story short, every single blood vessel, capillary, arteries, veins inside the graft develops blood clots. Meaning, as soon as blood from the host entered the graft, it triggered the clotting cascade. So what will happen to the graft if every single blood vessel in it is filled with blood clots? It will die right away. Okay, so it will die right there. Okay, really fast. So this happens anywhere from, this can happen right there during the transplant procedure, right there on the operating table. Can also occur hours later, within 24 hours or up to 72 hours. So like I said, the only thing we can do about this is take it back out. I mean, that graft is gone. That graft is dead. So take it out and break the news to the family. You know, you're one of the few extremely rare patients who experience hyperacute rejection. So the signs and symptoms here, are you even going to be observing signs and symptoms if it occurs that fast? Nothing really. Okay, so just symptoms of, I mean, the organ failed like this, okay, in just a few hours. The second type, which is acute, occurs within 3 to 14 days. However, look at the next the statement, the phrase after the comma, or after many years. Okay. Now, acute rejection is not, it's also not a one-time occurrence. The nature of an acute rejection is this is due to cytotoxic activity of the host immune system, meaning because we don't have a matching HLA, we settled for close enough. Will that graft ever be accepted by the host immune system? Meaning, let's say it's been there for 10 years, 20 years. Isn't the host immune system just going to say, you know what? You're okay. No, we'll stop killing you. Okay. So it turns out you're not really foreign. Will that ever happen? No. That host will always recognize the graft as foreign. So it's the host immune system lifelong mission to destroy that graft because it is a foreign object. Okay, what is this foreign object still doing here? So they'll continue to try to kill it. So therefore, the only way to keep it from being killed is to do what? To give immunosuppressive therapy. So the patient, the organ transplant, so this applies to every organ transplant recipient. They will always be on multiple or anti-rejection medications. We'll look at a few of those drugs shortly. There's a table for it. So in acute rejection, because the patient has started immunosuppressants even before the transplant, so before, during, and of course, forever after the surgery, you know that you've heard the phrase that what doesn't kill you makes you stronger. Okay, so that's exactly what happens here. So the immune system, no matter how you suppress it with medications, it will find a way to do its job. It will get around the immunosuppression eventually and then try to destroy the graft. So that's exactly what happens in acute rejection. That's why there's no one episode of this. So it can happen today. And then the treatment, by the way, is simply to increase the doses of the immunosuppressants, or we can add high dose steroids for a short time. Because the difference between specific cell-specific immunosuppressants and steroids is exactly the term. So let me just tell you the names right here. So tacrolimus is very common, as well as mycophenolate. So these are the two cheapest and most commonly used anti-rejection medications out there. So we got mycophenolate and tacrolimus. Okay, very, very effective immunosuppressants. And the good thing here is they are specific. For instance, tacrolimus is a calcineurin inhibitor. So it only inhibits helper T lymphocytes. It does not affect the rest of your immune system, only the helper T lymphocytes. Why these types of cells specifically? These are the ones directly involved in organ transplant rejection. Okay. And for as far as the mycophenolate, they are also affecting T and B. B are, of course, the memory lymphocytes. Yeah. So B cells help remember, and then, these are responsible for making antibodies, basically. So this drug affects both T and B lymphocytes. Again, does not affect the rest of the immune system cells. The problem with steroids, which we have no choice but to use when there is an acute rejection episode, is steroids, high-dose steroids do not discriminate. They do not target specific cells of the immune system. It targets everything. So that's why, what you remember from last week when we talked about Cushing syndrome? Okay, so plus there's also the possibility of Cushing syndrome developing. Okay, but we, of course, we have no choice. If we intend to save the graft, then we have to put them on steroids, but not forever though, unlike in Addison's disease or after adrenalectomy. Okay, so just for a few months, okay, until the rejection signs and symptoms subside, and then we can put them back on their usual tacrolimus and mycophenolate doses. Okay, so that's what we do for acute rejection. But like I said, it does not happen one time. It may happen again in the future. So basically, the immune system is just simply waiting for another opportunity to try to destroy the graft. Okay? And then lastly is the chronic transplant rejection. Now, because of the presence of the foreign object for years or decades now, and because it's a foreign object, so what will happen if you have a foreign object somewhere in your body? Let's say a wood splinter, or no, I mean, if you have something inside your body, what will it create? Inflammation. Yeah, it creates an inflammation. So what happens here is there's a certain degree of inflammation, and what always happens when there's inflammation? Vasodilation, there's swelling. Yeah. Okay, so if that's the case, then little by little, the graft actually, a few cells at a time, gets killed off. Okay, but it's very slow. The onset is very slow. We're talking just a few cells over a period of months, over a period of years. So therefore, can you observe it happening? No, it's so insidious. And by the time we actually discover that, oh, this is chronic rejection, is it still salvageable?
Yes.
Well, you can
Yes.
delay because we can delay just like remember CKD? What was the treatment for CKD? And did we like avoid nephrotoxic substances? You know, we did change the diet. Okay, that's basically what we can do here. So once we discover the doctor identifies signs and symptoms of chronic kidney rejection, then all they can do is modify the patient's diet, avoid any other harmful substances, you know, modify the patient's medication list, monitor the patient's kidney function more often until it eventually fails. And then status quo resumes, which means the patient is right back where they started as, you know, before they got the transplant. Yeah, because that graft failed again. And then now they're eligible for another kidney transplant.
The
Okay.
bottom or the top?
I can't comment on that because even if you're on the list, it's all about money, right? Yeah.
Not in
I
America.
don't know.
Well, you've seen, you know, Alonzo Mourning. Who else got organ transplants? Right. And then for the drugs, everything in table 48-4 are used, although like I said, tacrolimus and mycophenolate are the two most commonly used, but the others also I've seen. But since tacrolimus and cyclosporin are both calcineurin inhibitors, therefore they share the same side effect. Any questions? That's it for organ rejection. So we'll only stick with the kidneys. Okay. You know what? No, we won't. Let's look at liver also.
So this situation that chronic and hyperacute for any transplant, regardless on what tissue it is, body gonna affect the standard.
Yeah, because we use the same medication regardless of which organ was transplanted. However, signs and symptoms will of course vary. So for the kidneys, if it's acute rejection, basically what signs and symptoms of failure do you see? Acute or chronic?
You're gonna see.
For acute rejection, what signs and symptoms of rejection of kidney failure do you see? Acute kidney failure. And for chronic kidney rejection, chronic kidney disease. So you'll see the same pattern. So we'll look at heart transplant also.
With the immunosuppressive, are these people at risk of catching infections?
Of course, because that is the number one listed side effects on table 48-4.
Will the infection come from the graft or will it come from something else?
No, they'll get like pneumonia, the flu, no, something else, not necessarily related to the kidney. Meaning, are they one of those listed under your risk factors for septic shock?
Okay.
Yes, they were listed as immunosuppressed people, right? Yeah, so they are immunosuppressed. I don't have a chart or a table for heart transplant rejection manifestations, but basically we finished heart failure last semester. Will the manifestations be any different? It'll be exactly the same. The only thing I can add probably is new onset bradycardia. That's usually specific to, although we see that also in acute myocardial infarction, but it is seen in heart transplant rejection. Okay, new onset bradycardia. And finally, for liver, so we'll just do 3 organ transplant signs and symptoms: kidney, heart, and the liver.
Section of heart transplant, that was wrong, unfortunately.
Just the manifestations, because again, the medications used are the same as in table 48-4. So liver transplant is page 1407. What are manifestations of liver failure? Jaundice.
Cirrhosis. No, that is.
Hepatomegaly.
What happens to bleeding time?
It will decreases.
Increases. Okay, why? Why does bleeding time increase in liver failure? Okay, because the liver makes the clotting factors. What happens to albumin levels? Decreases also. So when your overall liver, liver function decreases and therefore albumin levels drop, what will happen to fluid balance?
Increase.
There will be edema. Okay, there will be ascites, there will be edema. All right, so that's basically the manifestations. Okay, no different from liver disease. And that's it for transplant and transplant rejection.